Hello everyone, it's Dr. Locklear here, and I'm coming to you with Chapter 14 of Maternal Child Nursing and talking about nutrition for childbearing. This starts on page 260 in your McKinney book. So let's get started. What are your learning objectives? We will explain the importance of adequate nutrition and weight gain during pregnancy, compare the nutrient needs of pregnant and non-pregnant women, describe common factors that influence a woman's nutritional status and choices, describe how common nutritional risk factors affect nutritional requirements during pregnancy, compare the nutritional needs of the postpartum woman who is breastfeeding with those of the woman who is not breastfeeding. Apply the nursing process to nutrition during pregnancy, postpartum, and lactation. And this slide here will be for your YouTube link. Weight gain during pregnancy. At no time in a woman's life is nutrition as important as it is during pregnancy and lactation, when she must nourish her own body and that of her baby. Nurses have ongoing contact with women and provide education about nutritional needs throughout this period. This is especially important because women do not adequately understand the nutritional needs of pregnancy. Nutritional counseling can also be offered before conception to improve chances of a healthy pregnancy. So as we talked in chapter 13, you may want to go get antepartum education, and nutrition would be one of those before you decide to get pregnant. Weight gain during pregnancy. Weight gain during pregnancy, especially after the first trimester, is an important determinant of fetal growth. Insufficient weight gain during pregnancy has been associated with low birth weight, less than 2,500 grams or 5.5 pounds, small for gestational age infants, preterm birth, and failure to initiate breastfeeding. Poor maternal weight gain indicates not only lower caloric intake, but also lower intake of other important nutrients. Excessive weight gain is another problem and is associated with increased birth weight, macrosomia, which means a large baby, C-section birth, postpartum weight retention, low APGAR scores, and the APGAR score is what you get when the baby's born to determine respiratory status and reflexes, and you'll talk about that at a later time. Hypoglycemia and overweight in children. So what is the recommended weight gain during pregnancy? Recommendations for weight gain in pregnancy are based on the woman's pre-pregnancy weight for height and body mass. BMI is calculated by dividing the weight in kilograms by the height in meters squared. Another method is to divide the weight in pounds by the height in inches squared and multiply the result by 703. Suggested gains vary according to the woman's BMI or weight for height before pregnancy. See table 14.1 on page 261 for recommended weight gain totals. Women who are underweight should gain more weight to meet the needs of pregnancy as well as meet their own need to gain weight. They should gain 12.5 to 18 kilograms or 28 to 40 pounds. The recommended gain for overweight women is 7 to 11.5 kilograms or 15 to 25 pounds. Obesity is a growing problem. Obese women who become pregnant have an increased incidence of spontaneous abortion, gestational diabetes, gestational hypertension, preeclampsia, prolonged labor, C-section birth or cesarean birth, postpartum hemorrhage, wound complications, macrosomia, and congenital anomalies. Their children have an increased risk of childhood obesity. Overweight and obese women should be advised to lose weight before conception to achieve the best pregnancy outcomes. The recommended weight gain for the obese woman is 5 to 9 kilograms or 11 to 20 pounds to provide sufficient nutrients for the fetus. Lower weight gain or weight loss for obese women during pregnancy is not recommended at this time, as there is insufficient evidence about the effect of neurologic development on the infant. In the past, women of small stature were advised to gain the lower limits of recommended range for their pregnancy weight. Adolescents were advised to gain to the upper limits of their pre-pregnancy weight. Evidence to support these guidelines has not been found. Therefore, the women should gain according to the recommendations for their BMI. Infants of a multifetal pregnancy are often born before term and tend to weigh less than infants born of single pregnancies. A greater weight gain in the mother may help prevent low birth weight. The recommended gain for women of normal pregnancy or pre-pregnancy weight who are carrying twins is 17 to 25 kilograms or 37 to 54 pounds. When these women meet the recommended weight gain, they are less likely to deliver their twins before 32 weeks of gestation, and the infants are more likely to weigh more than 2,500 grams or 5.5 pounds. Patterns of weight gain. The pattern of weight gain is as important as the total increase. The general recommendation is for an increment of approximately 0.5 to 2 kilograms or 1.1 to 4.4 pounds during the first trimester, when the mother may be nauseated and the fetus needs fewer nutrients for growth. During the rest of the pregnancy, the expected weight gain for women of normal pre-pregnancy weight is 0.35 to 0.5 kilograms or 0.8 to 1 pound. Distribution of weight gain in pregnancy. Women often wonder why they should gain so much weight when the fetus weighs so little. Explaining the distribution of weight helps them understand the need. Knowing about factors that may negatively influence nutrient intake and weight gain helps the nurse devise plans for improving nutrition. Women at risk for inadequate weight gain include those who are young, unmarried, low income, poorly educated, in poor general health, or receiving insufficient prenatal care. Multiparas are higher risk for low birth weight than primiparas. Smoking or substance abuse may interfere with food intake and weight gain. And smoking also causes vasoconstriction, so you want to not smoke, because if we cause vasoconstriction, then you're going to have issues with delivery of appropriate blood supply that is oxygenated as well. Nutritional requirements during pregnancy. And I think we've already talked about this here. So what are carbohydrates? Carbohydrates may be simple or complex. Simple carbohydrates are table sugar and candy, and those found in fruits and vegetables. Complex are present in starchy foods such as cereal, pasta, and potatoes. They supply vitamins, minerals, and fiber. Because of their value in providing other nutrients, complex carbohydrates should be the major source of carbs in the diet. Fiber, the indigestible carbohydrate in plant foods, is important because it produces bulk in the diet. Fiber absorbs water and stimulates peristalsis to prevent constipation. And that constipation, if you prevent it, then you're not going to be straining and cause hemorrhoids. It also slows gastric emptying, causing a sensation of fullness. You also have fats. We need a certain amount of fats, and then we need a certain amount of calories as well. So make sure you read over fats and calories. And then it talks about protein. The daily recommended RDA for females is 46 grams, depending on their age. During the second half, the protein of 71 grams. And so you see it increases as we go along. And so some of the foods that you will see for the protein, of course, are our meats, and you want to eat low-fat meats. You should eat more protein-rich foods rather than use high-protein powders or drinks. So eating the foods are best. Vitamins, for most people, the daily intake of each vitamin is not always as high as recommended, but true deficiency states are uncommon in North America. And again, look at table 14.3, which is on 264, and this is your dietary reference intake, and this is recommendations for vitamins and minerals. And as you see, we all need A, D, E, K, ADEK. You'll hear more about that in UR 211 too, but vitamin A, D, E, and K, and then those are your fat-soluble vitamins, and then your water-soluble vitamins are your Bs and folic acid, thiamine, and riboflavin, and so forth. And you might have covered that in pharmacology too, because I did when I taught pharmacology in the fall. We covered ADEK as well. The fat-soluble vitamins, again, are ADEC, and the water-soluble vitamins are B6, B12, C, folic acid, thiamine, riboflavin, and niacin. They should be included in the daily diet because excess amounts are excreted in the urine. These vitamins are easily transferred from food to water. Food should be steamed, microwaved, or prepared only in small amounts of water because you can lose those in the water. Folic acid or folate can decrease the occurrence of neural tube defects such as spina bifida and anencephaly in newborns. It may also help prevent cleft palate, cleft lip, and some heart defects. A1 of folic acid is especially important just before conception and during the first trimester. Because approximately half of pregnancies are unplanned, all women of childbearing age should consume adequate amounts of folic acid every day. The recommended amount of folic acid for women capable of childbearing has been 400, but the U.S. Now recommends 400 to 800. The dose should be taken for at least 1 month before and for 2 to 3 months after conception. There's been no change in the recommendations of 600 micrograms of folic acid daily for the rest of the pregnancy. Women who take anticonvulsants or have previously had an infant born with a neural tube defect should take 4 milligrams daily before conception and during the first trimester. Women often do not realize the importance of folic acid in their diet, and so a lot of women take these multivitamins before while they're in the pregnancy stage, but a lot of them will take them at night before they go to bed because they're so nauseated during the day, and they say the multivitamin causes even more nausea. Make sure you read about the minerals. You also need iron and calcium and sodium. Make sure that you read over those. And folic acid and iron are imperative to the development of the fetus, especially in the early trimester. Down at the bottom on page 263, it said absorption of iron is affected by intake of other substances. Calcium and phosphorus in milk and tannin in tea decrease iron absorption from non-hemi iron if they are consumed during the same meal. Coffee binds iron, preventing it from being fully absorbed. Antacid phthalates, which is in grains and vegetables, oxalic acid in spinach, and ethyl, I can't even say that word, is a food additive, also decreases absorption. Foods cooked in iron pans contain more iron. Foods containing ascorbic acid or vitamin C and meat, fish, or poultry eaten with non-hemi iron containing foods may increase absorption. So it's very important to take the iron. It's difficulty of obtaining enough iron in the diet. Healthcare workers often prescribe iron supplements 30 milligrams a day. If you're anemic, 60 to 100 milligrams a day. Iron taken between meals is absorbed more completely. Side effects occur more often with higher doses: nausea, vomiting, heartburn, epigastric pain, constipation, diarrhea, and black tarry stools. Taking iron at bedtime makes it easier. For best absorption, it should be taken with water or juice, but not coffee, tea, or milk. Keep the iron, like all other medications, out of reach of children. Accidental overdose with iron is a leading cause of childhood poisoning. And then it talks about calcium. And of course, we know that calcium is transferred to the fetus in the last trimester, and it's for the fetal bones and the teeth. So make sure that you read that about the sodium as well. Nutritional supplementation. And here are foods that are high in sodium. We know that. Canned foods, processed foods, potato chips, those type of things. Food precautions. And before we get to that slide, let me go back again to nutritional supplementation. Make sure that you review, just know the vitamins A, D, E, K, and then B6, B12, folic acid, thiamine, riboflavin, iron, calcium, vitamin C, niacin. Just have a general understanding that these are what they need during pregnancy. Pay attention to page 266, table 14.4, foods high in iron. Make sure that you review this, okay? Because as a nurse, you may have to do education and you need to know what foods to teach them. 14.1, calcium sources. It gives you a whole list, and the slide before this one had that on there. It talks about foods high in sodium, and it lists those as well. Please review this page. You probably see some test questions pertaining to something similar to this. And then food precautions. This is on page 267. You have a safety alert box down at the bottom. Do not eat shark, swordfish, king mackerel, or tilefish. Eat up to 6 ounces of canned albacore weekly. Eat up to 12 ounces of shrimp, canned light tuna, salmon, pollock, and catfish each week. Do not eat raw or undercooked food. Avoid lunch meats and hot dogs unless reheated until steaming hot. Avoid soft cheese, brie, feta, blue cheese, camembert, blue vein cheese, etc. And unless it's made with pasteurized milk, not unpasteurized milk. Do not consume refrigerated pate or meat spreads. Pate is like it's like a liver type of pasty spread. It's made out of liver. And refrigerated smoked seafood, raw or undercooked eggs, unpasteurized milk. So make sure that you review especially 266 and 267. Factors that influence nutrition: age, nutritional knowledge or lack of knowledge, exercise. Exercise helps our bones get the calcium that it needs. A serving of fruit, yogurt, or pasta before and after exercise may be sufficient. Additional fluids should be taken during and after exercise as well. And then culture. Again, we talked about the different cultural practices, and you make sure you read over Southeastern Asian diet practices. This is where I was talking on chapter 13, where they talk about hot foods and cold foods. And sometimes during the postpartum period, cold, partly because of the loss of blood, which is hot. And then Hispanic dietary intake, again, they may refer to hot and cold foods as well. And it talks about hot, spicy foods and different kinds of beans. Make sure you read over that. Also, on this page 268, it talks about Jewish women follow a strict kosher diet. They avoid meat from animals with cloven hooves. The Native American population may contain blue cornbread, potatoes, wild greens, legumes. So make sure you read over that. Different cultures have different practices. Nutritional risk factors: poverty, because they can't get to the doctor and they can't get the type of foods that they may need, and they eat a lot of fast foods. Adolescents, because of the nutritional needs are greater because their body's still growing and maturing as well. Vegetarianism, this is people that don't eat meats. They only eat vegetables, and they don't always have the protein and nutrients in it that they need. Lactose intolerant, which can limit the amount of essential amino acids and calcium that you need in the diet. On page 270, it talks about vegans. They avoid all animal products, and they may have the most difficulty meeting the needs. Vegetarians whose diets include milk products, lacto-vegetarian, eggs, ovo-vegetarians, or meat products and eggs. These are lacto-ovo-vegetarians. And so just make sure that you know that, okay? Also, again, the nausea and vomiting. You can't keep anything down, so you're not taking enough in. Some women are already anemic just from having their normal menstrual cycle every month, and now they're pregnant and their levels are low. And it gives you here the recommendations for hemoglobin and hematocrit and your ferritin levels as well. Other risk factors: pre-pregnancy weight not being adequate enough, eating disorders, anorexia nervosa, refusal to eat because of distorted body image, or bulimia. This is where you overeat and then you induce yourself to vomiting up everything you eat, which causes severe damage to the esophagus and severe nutritional deficits as well, because as the food comes back up, it irritates the lining of the esophagus, and it can cause ulcers and all of that, and makes it even more difficult to eat. Pica or pica, the practice of eating non-food or some food components not considered part of a normal diet is called pica or pica. Ice, clay, dirt, and laundry starch or cornstarch are the most common materials, but other items such as chalk, baking soda, toothpaste, freezer frost, coffee grounds, and antacids may be included. It is practiced by 20% of the women. It's more common in rural areas, inner cities, southeastern United States, African Americans, women who live in poverty, and those with poor nutrition. The cause of pica is unknown, although cultural values may be involved. It may be related to beliefs about the effect of the material eaten on labor or the baby. Iron deficiency is also associated with pica. Clay and dirt are not sources of iron and may decrease the absorption of iron and nutrients. Zinc deficiency is also associated with pica. So pica can be harmful. Ingesting substances may be contaminated with parasites, organisms, or toxins such as lead. Clay and dirt may cause constipation, intestinal blockages. Another concern is it decreases the intake of foods, and some women fear that eating their habits are harmful but are unable to ignore the cravings. So pica is very, very serious. Okay, and then there are other risk factors such as food fads and substance abuse, and then if you are having more than one child, multi-parity or multi-fetal pregnancy. Other issues with substance abuse: smoking causes vasoconstriction. Caffeine should be limited or avoided. It appears that caffeine intake less than 200 milligrams a day is not a major contributing cause of miscarriage. Alcohol, women should avoid alcohol completely during pregnancy. Interferes with the absorption and use of B12, folic acid, and magnesium, and often takes the place of food. Vitamin mineral implementation may be necessary. And then, of course, drugs, and it talks about heroin, cocaine, amphetamines. All of this affects fetal growth as well and absorption. Nutritional assessment, what do? We want to interview, we want to ask about their appetite, their eating habits. We want to talk about their food preferences, and we want to talk about their psychosocial influences. So when you're doing the interview, you need to make sure and ask about these things. The physical assessment, you want to weigh at the initial visit. Weight should be done every visit, and then notice signs of nutritional deficiencies. Ask them what they're eating, and look for weight loss and changes in skin color, and just decrease urinary output, and they'll tell you that they're not gaining any weight. And you want to look for signs of that nutrient deficiency as well. So also of concern is if they're going to be lactating, we need to talk about those needs as well. And so during the physical assessment, again, you want to look for women who are not gaining weight. They should not be dieting during pregnancy. They need to gain weight. Okay, so make sure you read page 273. Okay. Again, laboratory test. They cover a lot of that in chapter 13, and so You want to do a diet history, food intake records, and food frequency questionnaires. And so you definitely want to see what they're eating and, if it's enough and if it's the right kinds of foods. And they need, again, lean meats, some dairy products if they're not lactose intolerant. They need stuff with vitamins in it and stuff like that. Nutrition after birth. A lactating woman should consume an added 330 calories daily during the first 6 months. Maternal storage supplies an additional 170 calories because if you're lactating, you're still producing, your body's still in a state of, producing that milk for the child. You need a daily intake of 400 calories over non-pregnancy requirements is needed for daily during the second 6 months after birth. The postpartum woman who is not breastfeeding requires no added caloric intake other than just a regular diet. Now, if they lost a lot of blood, during the delivery and all, then they need to, eat a normal diet to get their iron stores and proteins and nutrients back up to par. Specific concerns during lactation. Dieting or inadequate dieting, adolescents, vegan diets, again, use of alcohol, caffeine, excess fluids, and foods to avoid. Lactating mothers are often concerned about whether they should avoid certain foods that might adversely affect the infant. Studies shown that eliminating allergenic foods may be helpful for infants under 6 weeks of age with colic and when infants have a confirmed food allergy. There is no insufficient evidence to recommend an elimination diet for other mothers during lactation. Infants at risk of developing allergies should be breastfed for at least 3 months. So again, when you're looking at specific nutritional concerns, this is on page 273, and it also talks about nutrition for the lactating mother as well here.